Um, I see an increasing amount of chatter on Facebook about juvenile spondylitis, and I'm sure there's lots of people in this room who probably started with their arthritis in their teens. So it's a great pleasure to have Dr. Shirley Tse here. She received her medical degree from the University of Toronto and completed her postgraduate training in pediatric medicine and pediatric rheumatology at the U of T in the Hospital for Sick Children. This was followed by a CIHR fellowship with further PhD training in immunology and cell biology at the University of Toronto, where Dr. Tse studied the human host response to pathogens. In 2003, she joined the rheumatology division and was appointed assistant professor, thereafter promoted to program director for the division of rheumatology in July of 2007. Dr. Tse's clinical and research interests are focused towards juvenile spondyloarthritis, I can't say the other word, the diagnosis, classification, radiologic imaging and treatment, and in education, the development of innovative methods for teaching pediatric rheumatology. Dr. Tse is one of the collaborating experts of SPA, and she focuses on pediatric SpA. So, Dr. Shirley Tse.
So thanks very much for having me today. And you know, the message that really I want to kind of give out is that spondyloarthritis can happen either beginning or during the childhood years. And as we have a saying at Sick Kids, that children or teens are simply not, small adults. There are some unique or distinct things that we have to take into consideration in how we approach and manage this. So to really start that off, this is a typical case that may walk into my clinic. And so this is Timothy, and he was a 13-year-old male who actually came with almost over a 5-month history of hip pain, lower back pain, and significant heel pain. They were also concerned because Timothy had some problems with gaining weight. And when we questioned Timothy and his parents, we found out in the family history there was a history of ankylosing spondylitis in a father and in his paternal grandfather, and both of these individuals were HLA-B27 positive. So some of the questions that kind of come up, from Timothy or even his family is, what's wrong with me? And, am I going to wind up like my father or my grandfather? Is this condition treatable? A common question that gets asked by us all the time is, as a child or a teen, am I going to outgrow this? Will it just go away on its own? And kind of like, what are the next steps? So to really understand that, what is juvenile spondyloarthritis? So when we look at this, it's kind of like an umbrella term that encompasses, different things. So when, occurs with distinct features, or what we call as differentiate side, so the right-hand portion of that, we do have some children or teens that present with that. If it primary up front involves, parts of the spine or sacroiliac joint, we can see kids with true juvenile ankylosing spondylitis. If it occurs with joints or with psoriasis, we call that psoriatic arthritis. If they get multiple kind of, inflammation of joints after infection, we call that reactive arthritis. And of course, if it involves the gut, we call that arthritis with inflammatory bowel disease. But I would say to you that the majority of our patients actually don't fall on this right-hand side, but actually start off on the left-hand, what we call as undifferentiated. That they often come with inflammation in their joints, or what we call as arthritis, or where the tendons join into the bone, or enthesitis. So hence today, we call that enthesitis-related arthritis. So it's a subtype of juvenile idiopathic arthritis or childhood arthritis. And that's where the majority of our patients will fall into. So the question is, how common? So many of you will be surprised to hear that 1 out of every 1,000 healthy children actually has childhood arthritis. And about 20% of those will have this form of arthritis, juvenile spondyloarthritis. And on a good note, or maybe not so good, 2.5% will have enough to fulfill, criteria for ankylosing spondylitis. So 2.5% will have juvenile ank spon, but the majority will have that undifferentiated form. But the bigger question, what we need to find out of the bigger population, is how many will eventually go on to develop the true forms of ankle spondylitis, because that's what's associated with, most of the disability or problems later on. Overall in this group, we do find, if we look at this population, they do tend to be more males than females, but it can occur in females. Older age for us means kind of presenting in their tweens or teenage, so as opposed to the common form of childhood arthritis where they kind of present in their preschool age. And oftentimes there's a positive family history, okay, of the B27-related diseases that we heard about in the beginning. So what does it look like? And this is what we have to educate not only, the families yourself to look at it, because some of you will have children and you wonder, wow, could this happen to my kids? But also, again, to those frontline people, the general practitioners, the pediatricians, chiropractors, other people that may deal with people presenting with back pain. So the interesting thing is most of the kids will actually, in contrast to the adults, have more what we call peripheral involvement. So involvement of joints outside of the spine or the sacroiliac joint. And the common places is they'll have joints involving areas of their lower limbs. So that's what we have to pay attention to, that they'll have involvement of the hip, of the knees. And actually uniquely, they'll often have involvement of the ankle and the small bones of the foot where they're all inflamed, and we call that tarsitis, where they can present with a painful and swollen foot. There are some patients, although it's probably unusual to present with the spine up front, but some patients may have what we call axial involvement, but it usually in kids shows up in that sacroiliac joint that we heard about before. So when we're looking at kids, the same things hold. Sometimes the earliest signs and symptoms of back pain, but also we pay very careful attention to the flexibility of the back. So one of the things that we do, as I'm sure all of your clinic visits, is we also do measurements in the back, and there have been normal values established for kids, and when you start losing some of the flexibility back, we have to be a little bit, aware to do further investigations. One of the investigations that we've heard about that really helps to pick that up early is with the MRIs. And in fact, when they actually looked, some studies out there looking at children who are B27 positive, they actually found that although the majority, all of these, really had normal x-rays of this area, the lower back of the SI joint, up to a third of these patients actually were found to have some of those, high signals or signals of inflammation in that sacroiliac region. So the question sometimes is if the axial involvement is the first, sign of the initiation of ankylosing spondylitis, are there particular features or who's at risk for getting, sacroiliitis? So if we look overall at our population of kids with arthritis, 6% of those will identify as developing sacroiliitis. But the timing is very unusual right at presentation. And it often may take sometimes between 5 or even up to 15 years before we see that. But now that we've studied a lot of these children, some things have come up that we identify as, people who are at higher risk of this happening. So obviously this HLA B27 marker is very important, okay? The other things we've learned is if we actually have hip involvement or hip arthritis, usually within 6 months of the start of the disease, it does put you at slightly higher risk. And obviously for us, if the onset of their arthritis occurred, after age 8, particularly in a male, because most of the childhood, forms of arthritis occur a little bit more in females and usually at a much younger age group. So this needs to, help us identify and put on the radar who is at high risk and that we need to kind of follow a little bit more carefully. So the other thing that we find unique to children is the inflammation of where the tendons join to the bone, or enthesitis. This is very common in kids, and if we look at some of the studies that we looked at, either kids with what we call as the differentiated, so juvenile angst versus those that had the undifferentiated forms in the blue bar, this occurred between 60 to 80% of those children and teens. Very common, again, presenting in areas in the lower limb around the knees, the Achilles, down at the bottom of the heel. So one of the messages we give out is unless somebody's participating in really intense sports, an otherwise healthy child who's presenting with severe heel pain or foot pain, we have to be a little bit suspicious of this. And again, these are things that we can see, swelling, either when we examine the children, and also sometimes we can see signs of that even on x-rays, where the Achilles tendons join in. We can see that there's a little bite here, and also that there's irritation, that you get kind of bony spurs that develop at those areas of irritation. So you can imagine why it's so painful for these kids to walk. They're kind of walking on these little spurs or spikes in their feet. In kids, if we look at the areas outside the joints, again, very commonly these kids can have the iritis, so that very painful red, light-sensitive eye. But unique to kids also, sometimes common areas involvement of the gut, or inflammation in the gut. So again, children who are having a lot of tummy pains, or poor growth or poor weight gain, that's something else that we have to really look carefully into. So I think, how do kids differ from adults? I think they have more of the enthesitis. They also have more arthritis outside the spine or sacroiliac joint at disease presentation. They can also have that unique swelling of the ankle or the foot, or what we call tarsitis. And I guess not so much different, but similarly, they can have involvement outside of the joints, and the most common areas are the eyes and the gut. So the question is, how do you diagnose this? What are we looking at that makes us comfortable to make a diagnosis? So when we look out there, in the yellow are really criteria that are set up for adults, okay? And some of them have sometimes been applied to kids. What's set up more uniquely for kids is what we call there's a criteria for childhood arthritis. It's called the ILA criteria, and in particular this group we identify as the enthesitis-related group, or ERA. So how does that work? So under the criteria, and this is set up and it's used kind of by rheumatologists or pediatric rheumatologists worldwide, to have ERA, you either have to show signs that you've got inflammation of the joints and the entheses. So if you have arthritis and enthesitis up front, you have this. If you don't have both of those things and you just have one or the other, there are some other things that make us suspicious. Obviously, if there's involvement of the sacroiliac joint, presence of that B27 marker, if there's a family history in a first-degree relative, okay, of those B27-related diseases, and that could be ankylosing spondylitis, psoriasis, psoriatic arthritis, inflammatory bowel disease, or iritis. Obviously, the child actually has episodes of that iritis, or what we call sometimes acute anterior uveitis. And again, if it occurs in a male, okay, greater than 6, okay, we have to be a little bit more suspicious. So we think back to Timothy and what he had. In fact, he fulfilled a lot of those criteria. So the diagnosis was, pretty easy in that case. One of the things that we also do is often we use imaging to help look for signs of arthritis or enthesitis, and in particular, any involvement of the spine or sacroiliac joint. I will tell you, though, in children, the findings on x-rays in the sacroiliac joint occur late, okay? And not to rely on that, because people can have very active disease in an area that you won't pick up on an x-ray. It will take sometimes between 5 to 10 years for some changes to occur. And so if doctors just taking an x-ray there, oh, it looks great, the child is fine, it may not be good enough if the child is actually having a lot of symptoms there. And the best way to pick it up is really with the MRI. So one of the special things that we have a dedicated spondyloarthritis clinic at Sick Kids, and we have really worked well with our radiologists to develop a protocol that we can use in kids. But because they also have involvement in joints outside the spine, okay, we can't just look at the sacroiliac joint. So we've developed a special MRI protocol that allows us to look at the whole body all at once. And it's just for you to know. So as you heard before, if you look at an MRI at one particular area, it takes about 45 minutes to an hour, okay? And obviously, I can't stick a child in there for a whole day and say, hey, let's spend the day there, okay? So we have actually worked well that we've developed a very special protocol that I can see everything in the whole body in the child in less than an hour. And it helps to pick up everything that we can see, what's happening in the spine, the sacroiliac joint, but also outside the joints. And this has been really useful for us to pick up disease early, because we know early treatment, early appropriate treatment makes a difference. So the question is, a lot of people ask, well, what's going to happen to these kids? What happens with their function if you have your onset, in your childhood years versus later on? Do they do better? Do they do worse? So there's been a couple of studies out there that actually looked at, patients diagnosed with ankylosing spondylitis, and if they had their onset, or symptoms occurring before their 18th birthday versus those in their later years, their adult years, how did they do? So initial studies back in, I would guess, like in 1988, some of the first glimpse of what happened there shows that, hey, kids actually did okay, but one of the things that came out is hip involvement or bad hip disease. A lot of these kids actually required hip replacements early on in their adult years, but overall they're still able to work. A little later study that came out of, that was published through the Toronto group, when they looked at that, some of the data came up, which is a little bit worrisome, that actually people who had this happen in their childhood or teen years actually did worse, that they had worse functional index. In particular, the women did worse. And so this was a little bit, alarming, but this was in the era. I think there's a transition, I guess, a move towards earlier diagnosis in some of the newer treatments, or particular biologics that have been exposed. And so, again, looking at a more recent study, again, is showing some better news, that the kids and teens with appropriate early diagnosis and treatment, and were doing well, they were functioning well. And the nice thing is they're showing that they're distinct, that the kids or teens have more peripheral involvement and less axial, or less spine involvement. That may relate to why they may be doing a little bit better. So these are people with true ankylosing spondylitis. The bigger question is in that hodgepodge group, the patients who just have ERA or just involvement of joints and entheses. What happens to these kids? So it kind of showed similar trends. Initially, earlier studies, when you compare it to the other types of childhood arthritis, these patients seem to be doing okay. They function well, A study that came out in 2006, when they compared it to the other types of childhood arthritis, again showed a little bit worse, that these patients were doing worse. They found that they were not functioning well. They were having more pain, more fatigue, and it seemed to be a little bit more chronic. We have a little bit of data now, because there's actually a study across Canada that looks at all kids with childhood arthritis across Canada, and we've enrolled all the kids and are following these kids to see how they do. So we've actually looked at some of the earlier data of how things are, what things are happening over the first year, and overall we're finding that patients with ERA are functioning well compared to the other subtypes of arthritis. What is a little bit worrisome, is that there's still a lot of active disease going on, even at that 1 year mark. And in fact, half of the patients with ERA still had ongoing inflammation in their joints. Up to a third still had, inflammation in their entheses. And, apart from, I think the worst type of arthritis, which is akin to rheumatoid arthritis in adults, so there are kids with juvenile rheumatoid arthritis, the ERA were basically, compared to how they're doing, second worst. All the other subtypes were doing much better. So it kind of tells us that, yeah, they're doing okay, but I think there's a lot more room that we can work together to do better. So the biggest question, obviously, is do we know anything about, of all those kids, who's going to eventually, follow the path of ankylosing spondylitis? So I think one of the things that we've learned, it's a myth that kids will outgrow their arthritis. And if we follow some of these kids, although they don't have spine or involvement in the sacroiliac joint up front, if we're following these kids over time, and there have been studies out there now that have followed them out to the 10 to the 15-year mark, the bottom line, if you just look on the right there, the signal that's coming up is about 40% of these patients will go on to develop changes that qualifies them for a diagnosis of ankylosing spondylitis. So you can look at the glass as a half full. So it means that 60% are doing well. This will not follow this course, but it's still concerning that 40% of these kids will follow a course that will lead them to ankylosing spondylitis. If we look at adults with undifferentiated, okay, it is a little bit lower because overall, if we look at the data in adults with undifferentiated, about 60% of those high-risk individuals will develop ankylosing spondylitis. So I think it does raise some concern. So overall, I think the disease can still be variable, okay? Kids will not outgrow their arthritis, okay? You do need help. We can bring kids to remission with help, whether or not it be a good treatment program with medications and the other things that we'll talk about in a moment. With help, okay, we can get remission, and sometimes remission off medication is possible with these kids, that we can see it, and sometimes probably in about half of these kids. So it doesn't mean that they're committed to lifelong medications, okay? But there is a subset for you to know that it will go on and they will always require help, okay? But at least on the outside, they can be functioning well and doing, you know, not putting their dreams on hold and being able to do whatever career or, you know, schooling that they can do later on. We know that the spine and the sacroiliac joint is not common at the very start, but it can occur in 40% of these individuals over the next 10 years. So that's something that we follow very carefully in following their measurements, following it with imaging to kind of look for it, because the earliest we see it, we act upon it. So the question is, how do we treat this? We saw a little bit from the slides before about the EULAR and AHS kind of recommendations. So in children, it follows the same principles. If you have involvement in mostly joints outside the spine, okay, you can use some, you know, traditional therapies, anti-inflammatories, joint injections into targeted joints, and sometimes using some of those DMARDs that we heard about. If it involves the spine or sacroiliac joint, okay, we know that the anti-inflammatories may not be so helpful. It helps with symptoms, but it doesn't really change a whole lot. And at least from the data in adults, because there's actually been no data in kids, that the DMARDs have not really been shown to have an effect on the spine, and really people move on to biologics. This just highlights again is that we have to think of the kids. You know, sometimes there's really a lack of data just because that there's no studies that have been carried out in kids. So at least for anti-inflammatories, there have been no studies in kids. But we know in terms of studies at least that have been done in I guess, in the peripheral joints, it does and is helpful with that. And because that's the most common presentation in kids, we often will use that. Similar for the DMARDs, okay, we don't really know if it has any effect on the spine, but again, because kids have involvement of joints outside the spine, there have been some studies that have been done in the juvenile spondyloarthritis population, or studies that have been done in childhood arthritis, which shows that, you know, agents such as sulfasalazine or methotrexate do help with peripheral arthritis, and that's why that is also something that we use in kids. And to let you know that if used appropriate with monitoring, this is safe, it's effective, and it doesn't affect with the growth and development of children or their ability, you know, to start a family later on. So it is something that we use. So the biggest news is really biologics. You know, is there any data in biologics in children? So you know, we've been part of some of the studies, some of the smaller studies, and there have been some studies that have been done in juvenile spondyloarthritis patients that have shown that with the biologics with, I would say, quickly and really well, does improve both the arthritis, the enthesitis, and a lot of things that go on, the stiffness, the pain, and one of the nicest things that we'll get some data, so the top three are usually etanercept or Enbrel, infliximab or Remicade, and there's currently an international trial that's going on right now with adalimumab or Humira, so that we will learn a little bit more and can allow access to our kids that need this, that it works well. One of these studies that we actually followed a child who had bad arthritis and enthesitis, that we were able to kind of follow serially over 2 years' time what happened in the joints with MRI, and you can see the dramatic effect. So things that are bright and white So this is a big joint effusion. This is an MRI of the knee. There's bright spots where the tendon is attached to the knee. And as we follow this child out, from 6 weeks, 6 months, 1 year, and 2 years, you can see virtually everything here is a normal MRI. That we were able, with that biologic, to completely get rid of the arthritis and enthesitis. So just something that I think you need to be aware of as patients or advocacy groups is that you need to know that oftentimes, like I was telling people, I almost feel like sometimes like Prince Philip. We're always 2 or 3 steps behind the Queen there, because there are many medications that are approved for adults for ankylosing spondylitis, but really if you look at what's approved for children, that list just shrinks, okay? And it's not because they're not effective. A lot of times is that we're missing, the extra steps to either, get approval from payers to pay for it for kids, or actually get the studies to prove that they also work and just figure out what the correct dose is. So at least just so that you're aware of right now, what's approved for kids with JSPA is really just Enbrel and Remicade. And even though there's lots of other medications out there, they're actually currently not approved, okay? And then just to let you know, so the EAP is, at least in Ontario, is the government kind of exceptional access program that, if you don't have full coverage from a private, health plan, or you have no coverage, again, the government just listens to say, oh, what's approved, and you can see that they limit, what kids can get. So that's something I think that you as a voice can take back, to your, either local or provincial reps, is that you have to, put the children or teens, because it doesn't make any sense that I have to let you wait and suffer until you turn 18 before I can get access to some of the other medications. The other thing that's important is sometimes the people who are deciding who can get access to these drugs, they don't always talk to us, or the experts in this field, or what makes sense. We've tried to do a lot of work about getting what are the criteria before either private insurance or the healthcare will approve. So it's just to give you an idea, they finally have considered ERA or JSP as a category, and people who get biologics for what they call axial involvement, we've worked somewhat with them, and one of the greatest things that we worked with them is actually inclusion of MRI, which is the best test to detect early disease, okay, to get access to biologics. Because before, they would only accept if there was X-ray damage there before they would let somebody have a biologic. And that was really, I think, not benefiting a lot of our kids and teens before. So there has been progress there. For the peripheral disease, there's still work to be done. So this is what they currently have, is that in order to get a biologic, okay, for joints outside the spine, you have to have at least 5 active areas, okay, and enthesitis in 2 locations. And obviously it didn't respond to either the anti-inflammatories or some of the DMARDs. So I think the bottom, is actually reasonable, but one of the things that really we've been, need to still have work to be done is 5 areas in the joints would be, in some patients, but not in the majority of patients. That it tends to be only in a few areas, and particularly if there's hip involvement and aggressive hip involvement, that in itself is a high risk that there's going to be damage there. So, we need to work with them as who's deciding. Something more appropriate might be if you want 5 areas, we should include that as a combination, either joints and entheses together, not distinct that I have to wait for a child, to get 5 joints before they'll even consider a biologic. So this is something that, again, I think is important for you guys to advocate with your government representatives. So back to Timothy. So I think we know that the pharmacologic or medication routes that we can treat his arthritis, we can use anti-inflammatories, perhaps a joint injection just into the hip, and unless, that didn't respond for him or he had sacroiliac involvement, that we would move on to other agents, including biologics. The other important thing that we've learned is exercise is very important in this population, okay? And it is something we have to work with, because I would say many schools do not have gym every day anymore. And so it's important to kind of encourage, kids to be active, proper footwear, and proper nutrition. So just to close, I think the good news is not all forms of juvenile spondyloarthritis will go on to develop ankylosing spondylitis. We still have to really work on that because of the kids that do have that, it can be associated with some functional impairment or disability. I think the key is earlier diagnosis, early recognition, and appropriate treatments is going to be the key in better outcomes. And I think the arthritis or the peripheral arthritis, I think the standard therapies with anti-inflammatory DMARDs are going to be useful. But I think the good news is really we have more evidence to show that some of the biologics, particularly anti-TNF agents, are very effective with the joints and disease in this population. And I just put a link at the bottom there. So www.aboutkidshealth.com there is a full JA resource center in there, but in particular there's a dedicated information on just on juvenile enthesitis-related arthritis, what it is, medication, exercise. There's even a unique section there just with teens, and this is free, it's available, and it's available in English, French, and also translated in Chinese. So definitely that's a source of information that you can go to. Thanks.